Hello, everyone. We'll just wait for another minute and then we'll start. Dr. Areeba, are you ready to present?
Yes, sir, I'm ready.
Please tell your friends to unmute to mute yourself. There's quite an echo. So I welcome you all to yet another session of the Residence Corner module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital. The idea is to orient the trainees with anatomy, 3D neuroanatomy, which is very important by performing neurosurgery. The topic of our discussion today is cellular anatomy. Dr. Areeba is a fifth-year resident at Liaquat National Hospital and she will be discussing cellular anatomy. Dr. Areeba, can you please start your presentation?
Yes, sir. Assalamualaikum, everyone. The topic of today's presentation is cellular anatomy. We will be discussing cellular anatomy in detail today, and the part of the cavernous sinus will be dealt later in the next session. So, starting from a simple schematic view of the cellular anatomy of what we are going to see today. This is an axial cross-section cut, and as we can see, this is above and this is below. We can see the optic chiasm superiorly. We can see the pituitary gland that is present in the hypophysis cerebri, and we can see the cavernous sinus, the vessels present in the cavernous sinus, internal carotid artery, the paired sphenoid sinuses, and the sphenoid bone itself. So we will be dealing with the sphenoid bone first, then we will look at the pituitary, and then we will look at the vascular and neurovascular structures that are present in the sellar region. Moving forward to sphenoid bone. Sphenoid bone is the main bone that makes up the sella. It's located in the center of the cranial base. The olfactory tracts, gyrus rectus, and posterior part of the frontal lobe rest against the smooth upper surface of the lesser wing, and the temporal lobe rest against the inner surface of the greater wing. We have pons and mesencephalon, which are going to lie posterior to the clavicle portion, optic chiasm and posterior to chiasmatic sulcus, and we have second to sixth nerve, which are intimately related to sphenoid, and they all exit the cranium via different fissures which are present in the sphenoid bone. So how does a sphenoid bone look like? So this is how the skulls look like from the inside. This is anteriorly, this is posterior, we can see the foramen magnum here. The bone that is outlined here in black, this is sphenoid bone. As we can see, sphenoid bone is bounded anteriorly by the frontal bones and laterally by the temporal bones. And posteriorly, we can see that it is basically present in the middle cranial fossa, and anteriorly is related to anterior cranial fossa and posteriorly to posterior cranial fossa. As we can see, it has a central body and wings. Let's look at it further. So we have a central body, and we have greater wings and the lesser wings. So basically it looks like a butterfly with a central body and wings. And as we can see, inferiorly we have two processes which is known as the pterygoid process. The one which is present laterally is known as the lateral pterygoid process or the lateral pterygoid plate, and the one which is present medially is a medial pterygoid plate. The body itself is composed of different sulci and gyra, which we will see in another view. In this view, we can appreciate the superior orbital fissure, which is basically a opening created between the lesser wing and the greater wing of sphenoid. See, as we can see, this is a big wing. So this is greater wing of sphenoid, and this is a smaller wing, a smaller projection from the body. This is known as the lesser wing of sphenoid. And the space or the foramen that is created between the lesser wing of sphenoid and the greater wing of sphenoid is known as the superior orbital fissure. We can appreciate the optic canal in it, which we will see further. We can see different foramens which are present on the greater wing of sphenoid, like foramen rotundum, and we can see the pterygoid canal. Let's look at it from another view. So this is a simplified schematic view of the sphenoid bone. As we can see, we have a central body. It's also known as corpus. We have a lesser wing, or also known as ella. Minor ella means wing, minor means small. We can see we have a greater wing of sphenoid bone, which is also known as ala major. Again, ala means wing, major means big. And we have two pterygoid process, a lateral pterygoid process and a medial pterygoid process. If you look at it from above, we can appreciate that this corpus or this body is further divided into different elevations and depressions. So if we're going to look from anterior to posterior, we can appreciate that we have the lesser wing of sphenoid laterally, and the part of the body which is present between the two lesser wing of sphenoid is known as the jugulum sphenoidum. Then we have a depression, which is known as the hypophysis sulcus prechiasmatic. Then we have an elevation, which is known as tuberculum sella. Then again a depression, which is known as hypophysis or sellar cavity proper. Then again an elevation, which is known as dorsum sella. And then we have the sellar turcica or clavus bone. So if we go from front to back, we have elevations and depressions. So if we are going to look at it, laterally, we will have an elevation first, then a depression, then an elevation, then a depression, and then again an elevation. Or I will draw it here so that it's a little bit more clear. It's kind of like this. So the first depression that we have here, this is this one, the prechiasmatic sulcus. Then we have an elevation, this one. This is known as the tuberculum sella. Then we have a depression where pituitary gland is going to lie. This depression, this is known as hypophyseal fossa or sellar turcica. And then we have an elevation again, which is known as dorsum sella. So tuberculum sella, hypophyseal fossa, then we have dorsum sella. And here we have chiasmatic sulcus anteriorly. So what are the normal dimensions of this sella? Normally sella is 17 millimeter in length. And why this is important? Because when we are dealing with pituitary surgery, these measurements are very important. Sellar width is defined as the width of the horizontal plateau of the sellar floor between the carotid sulcus. Where does carotid sulcus lie? So laterally here. We will see this in further pictures. So sellar width is defined as the distance between the two carotid sulcus. And sellar length is taken anterior-posteriorly. And sellar volume is going to be calculated by applying a simplified mathematical formula for the volume of an ellipsoid. That is, we multiply by the length to width and depth in millimeter divided by 0.5. The upper limit of the normal depth is 13 millimeter, length is 17 millimeter, width is normally 15 millimeter, and volume is approximately 1100 cubic millimeter. So this was all about the bone. Now we will look at the contents of the sella, starting from the main content, that is the pituitary gland, which, as we know previously, lies in the sellar turcica or hypophyseal fossa. When exposed from above by opening the diaphragma, which is the superior surface of the posterior lobe of the pituitary gland, is lighter in color than the anterior lobe. We know the pituitary gland normally consists of two lobes, an anterior lobe and a posterior lobe. So how are we going to microscopically differentiate between the anterior lobe and the posterior lobe? So the posterior lobe of the pituitary is a little bit lighter in color than the anterior lobe. The anterior lobe wraps around the lower part of the pituitary stalk to form a pars tuberalis. This is the hypophyseal gland. This is the stalk, and a little bit part of the anterior lobe basically wraps around the stalk. This part is known as pars tuberalis. The part of the anterior lobe that is going to twist around, or that is going to wrap around the stalk. The posterior lobe is often softer, gelatinous, and more densely adherent to the sellar wall, and the anterior lobe is firmer, more easily separated from the sellar. The gland's width is the same or more than either its depth or length in most patients. So as we can see, this is an anterior view. We are seeing from front, and as we can see, this is going to be the right side of the patient and this is going to be the left side. We can see the pituitary gland over here. This is the anterior lobe. And the part which is not visible to us right now is the posterior lobe. We can see the pituitary stalk here. So the part of the anterior lobe that forms a cuff around the stalk, this part is known as the pars tuberalis. And as we can see, this is optic chiasm. This is the bilateral optic nerve that are the right side is retracted. Again, we are viewing from superiorly, and as we can see, the two lobes of the pituitary can be appreciated. As we read previously, that posterior lobe cells are more firmer, they are more densely attached, and they are a little bit densely packed, jelly-like. Anterior lobe is a little bit looser, not very well attached, and this lobe, as we can see, the color is different. This is more grayish pink, and this is more yellowish pink as compared to this. So we can differentiate this. And as we can see here, this is the pituitary stalk. Again, showing a differentiation between anterior and posterior lobe, we can see the color difference here. We can see the posterior lobe is a little bit yellowish, paler as compared to the anterior lobe. Again, here we can appreciate a paler posterior lobe as compared to the anterior lobe. And this, as we can appreciate, is pars tuberalis, the part of the anterior lobe that is going to twist around or wrap around the pituitary stalk. Moving forward to sphenoid sinus, which is the main air-filled cavity in the sphenoid bone. So the sphenoid sinus separates the cavernous sinuses, the cavernous segment of the carotid artery, the optic, extraocular, and trigeminal nerves. It separates the pituitary gland from the nasal cavity, and it is present as a minute cavity at birth, but its main development takes place after puberty. As age advances, the sinus frequently undergoes further enlargement associated with the absorption of its bony wall. And due to this, the sphenoid bone and the sphenoid sinus in adult is divided into three types. We have a concal, a pre-sellar, and a sellar type of sphenoid sinus. So what does these words mean? Basically, it depends on the extent to which the sphenoid sinus is pneumatized. In a concal type, which is the most common type in children, C for conca, C for children, the area below the sella is a solid block of bone without any air cavity. Let's look at it in a picture. So as we can see here, we are viewing at the lateral view of a sphenoid bone. We can see that in this type, the one labeled in A, we don't have any air sinuses. It's look like a solid block of bone. This type of sphenoid is known as the concal type, and it is more common in children, in which pneumatization has not been done yet. As a child grows, the bone becomes pneumatized. So there are two other types of sphenoid bones, the pre-sellar type and sellar type. In the pre-sellar type, which is present in 24% of patients or people of sphenoid sinus, the air cavity does not penetrate beyond a vertical plane parallel to the anterior sellar wall. So as we can see here, this is sella turcica and a vertical line which is drawn from the anterior sellar wall. If the air sinuses are not present behind these lines, this is known as pre-sellar, before sellar type of the sphenoid sinus. Another type which is more common is the sellar type, present in 76% of the population. This is the most common, and here the air cavity extends into the body of the sphenoid below the sella as far posteriorly as the clivus. As we can see here, that this type, the one shown in C, is the sphenoid type, the sellar type. So if you are going to look at it, we have basically concal type, the one which is a solid block with no pneumatization, C for concal, C for children, more common in children. So we are going to encounter these in pediatric population. This is pre-sellar type. What do we mean by pre-sellar? That if you are going to draw an imaginary line from the anterior sellar wall, the pneumatization of the sinus will be present anterior to it. This is known as pre-sellar type. And then we have a sellar type, which we can appreciate here, that it's going to extend further till the clivus. Sometimes as the age advances, it's going to keep on invading, and the whole bone may become pneumatic or air-filled. So the most common type of sphenoid sinus is multiple small cavities in the large paired sinuses, and the smaller cavities are separated by septa oriented in one direction. So as we just discussed, that there are different types of sinus depending on the pneumatization. So as we can appreciate that these pneumatization does not occur themselves, they are happening in the bone. So the bone that is going to be resorbed by the air cell, and then a part of it will remain as septum. So different patterns of septalization which are present in the sphenoid bone. And why are they important? Is because usually these septas are attached to the carotids laterally. So if you're going to you are going for pituitary gland surgery and you open a sinus, and then you open a sphenoid sinus and you keep on removing these septa, and if you push them too hard or you if like pull them too hard, you can rupture the carotid artery. The most common present pattern of pneumatization is a single septum that is present in the midline. Now, as we have gone through the sphenoid bone, the sphenoid sinus and pituitary gland, let's move towards the cavernous sinus. So what is cavernous sinus? Cavernous sinus are located on each side of the sphenoid sinus, sella and pituitary, and they extend from the superior orbital fissure in front of the petrous apex, behind and surround the horizontal portion of the carotid artery. The medial wall of the paired cavernous sinus is from the lateral boundary of the sella. As you can see here, the cavernous sinus is going to be present in the lateral wall of the sella. We can see that this is a cross-sectional view. We are looking from above, from inside. This is going to be anterior. This is posterior. This is going to be right side of the patient, and this is left side of the patient. You can appreciate a pituitary gland in the center. This structure, this is the stalk of the pituitary. As we can appreciate that the diaphragma sella, or the upper part of it, has been removed. We can appreciate a tuberculum sella, that is the bony elevation that is present anterior to it, and dorsum sella, which is a bony elevation present posterior to it. We know that there is a depression here, which is known as the Sellar turcica hypophysis cerebri, where this hypophysis or pituitary gland lies. We can appreciate the both carotid arteries that are in intimate contact with the pituitary gland present laterally, cranial nerve 2 or the optic nerve present next to it. They both are covered by a single dural attachment, which we are going to see further. We can appreciate the anterior clinoid process here and posterior clinoid process here. Anterior clinoid process is present lateral to the tuberculum sella. Posterior clinoid process is present lateral to the dorsum sella. We can appreciate cranial nerve 3 entering into the cavernous sinuses. Okay. We can see the paired cavernous sinuses here. We can see the cranial nerve 4 here and third nerve entering into the oculomotor system. Now we will move on step-by-step dissection of this image. As we can see, we have a magnified view of the sellar region. One side's dura has been removed. As we can see, dura is present here, and on this side the dura has been stripped off. So we can see the tuberculum sella. We can see when it's going to be end laterally here, it will be the anterior clinoid process. In between the tuberculum sella and anterior clinoid process, the fold of dura, this fold of dura is known as the falciform ligament. This falciform ligament is going to cover or encapsulate two structures that are entering here and are going to exit through superior orbital fissure. These two structures are cranial nerve 2, the optic nerve, and the carotid. This attachment of dura, this is known as the falciform ligament. It's nothing special, it's just a fancy name of dura here. We can appreciate the third nerve, oculomotor nerve, entering into the same canal, same region. We can see the edge of the 10th that is present here. If you are going to strip further here, we can appreciate the cavernous sinus, which is going to be present laterally, making the lateral wall of the Sellar turcica. These cavernous sinuses are paired sinuses. This left cavernous sinus is visible in this diagram. The right side will be present somewhere here, and they will have intercavernous connections, which will be learning further on. We can also appreciate the cranial nerve 6 and the cranial nerve 4, which are going to present inside these dural attachments. Furthermore, opening the dural attachments here, we can appreciate, again, we are going at the same picture, same magnified view. From superior to inferior, we can appreciate cranial nerve 2 and a carotid artery covered in the falciform ligament, which is the dural attachment. If you're going to remove the dural attachment from here, we can appreciate the oculomotor nerve entering in the oculomotor system, and this is the fifth nerve. As we all know, the fifth nerve has 3 divisions, V1, V2, and V3, and all of them exit through different fissures. That we can appreciate, we can see the V3 or mandibular division of the trigeminal nerve exiting here from foramen ovale. We can appreciate the V2 or the maxillary division exiting through the foramen rotundum here. And as we saw previously in the first picture, that this is sphenoid bone, greater wing of sphenoid bone, which is going to form the middle cranial base. And so all the basics important phenomena are present here. And we can see the V1 division of the trigeminal nerve going further, and here it will exit through the superior orbital fissure, which will be present somewhere here if you are going to remove these two structures. So here we have just a magnified view of the falciform ligament, and as we can appreciate, we are basically viewing this part. We are zooming in on this part. So as we zoom into this part, this is going to be tuberculum sella. This is going to be the anterior clinoid process. This is your pituitary gland, and we can appreciate the fold of dura known as the falciform ligament, which is going to be present on the cranial nerve 2, optic nerve, and carotid. So moving on further, we are now seeing the connections which are present between the two cavernous sinuses. As we discussed previously, that they have paired cavernous sinuses which are present on the lateral wall of the sella. And the two paired cavernous sinuses are connected to each other through intercavernous connections or intercavernous sinuses. Obviously, the one which is going to be present anterior to the pituitary is going to be known as anterior intercavernous sinus, and the one which is going to be present posteriorly will be known as posterior intercavernous sinus. This posterior intercavernous sinuses are multiple, and anterior intercavernous sinus is single. So the multiple of the most important or the visible one in the posterior intercavernous sinus is known as the basilar sinus. So this is basilar sinus, which is connecting posteriorly the two cavernous sinuses, and this is anterior intercavernous sinus, which is going to connect the two cavernous sinuses anteriorly in front of the pituitary gland. And again, the same falciform ligament, optic nerve, carotid can be appreciated. We can appreciate V1, V2, and V3 division of the trigeminal nerve. We can appreciate cranial nerve 6 and cranial nerve 4 here. So moving further, now we are looking at these structures, the one which are present inferiorly a little bit further. So we can appreciate our normal pituitary gland here. We can appreciate pituitary stalk here, anterior intercavernous sinus. We can appreciate dorsum sella, posterior clinoid process. We can appreciate carotid artery, optic nerve, falciform ligament surrounding it. We can appreciate cranial nerve 5th, V1 division going above here in superior orbital fissure, V2 division going in the foramen rotundum, V3 division going in the foramen ovale. We can appreciate cranial nerve 4, a cylinder nerve, which is basically present in the free edge of the tentorium here. And we can appreciate cranial nerve 6. The point of showing this picture is to give an appearance or idea of the Dorillo's canal that we commonly see here. So what happens is that this is a petrosphenoidal ligament. As the name suggests, it's going to attach from the petrous apex to sphenoid bone. And this petrosphenoidal ligament is a basically fold of dura that make up a tunnel or a space, potential space, from which cranial nerve 6 enter inside the sellar region. And this area, this space, the potential space that is created is known as the Dorillo's canal. Moving further, we can appreciate that this falciform ligament has been opened a little bit. This here we can appreciate the optic strut and the clinoid rings. When we were discussing the internal carotid artery anatomy, we discussed that there were 7 components of 7 parts of the carotid artery, and one of the part was the clinoid segment. And when we were discussing clinoid segment, we discussed about the upper ring and the lower ring of dura that were present. So we can appreciate that upper ring and lower ring of dura here. That forms a clinoid segment of the ICA. So the part of the internal carotid artery, I think if you see a little bit clear, we have an imaginary. We can appreciate it. If we are going to remove this dura, this carotid artery goes something like this. So this segment of the carotid artery, which is present in between the upper ring and the lower ring of dura, this is the clinoidal segment of the ICA. It's just giving an impression how these segments of ICA are intimately related to the sellar region. Moving forward, we know this diagram very well. Moving from above, this is optic nerve, carotid artery covered by the falciform ligament, pituitary gland. We can see the carotid artery making turns around here. We can appreciate the 4th nerve here, slender, long, thin nerve. We can appreciate V1 going inside superior orbital fissure. We can see V2 going here in foramen rotundum. We can see V3 going here in mandibular division. In previous dissection, this nerve was lying something like this. So we have just retracted the 3 segments of the trigeminal nerve to appreciate the anatomy here, the structures here. We can appreciate a petrosphenoidal ligament and the petrolingual ligament. Petrosphenoidal ligament we learned previously, as the name suggests, start from the petrous apex, goes up to sphenoid bone. And the 6th nerve passes beneath it, below it. And this is petrolingual ligament. Okay. Moving further, we are viewing this part, the inferior part. We are viewing this part and we're zooming it. We can appreciate that this is the 5th cranial nerve. This has been retracted back. This cylinder thin nerve that is coming from behind the petrosphenoidal ligament is the 6th nerve. And as we can appreciate that here we have the carotid artery. These are different turns of the carotid artery. And like the way we discussed previously in carotid artery, that there are different branches that arises here, inferior hypophyseal artery, meningohypophyseal trunk. We can appreciate the inferior hypophyseal artery arising from the carotid. And as the name suggests, inferior hypophysis is going to be supplying the hypophysis or the pituitary gland. So we can see that it is going here in the pituitary gland. Another vessel we can make up here is this one. This is superior hypophyseal artery. And again, this also arises from the carotid artery. We can appreciate Vidian nerve here, which, as we can appreciate, is closely associated with carotid artery. Moving forward, and now we are looking at the vascular supply again. We can appreciate the carotid artery cut in cross section here. We can see the carotid artery going here like this. This segment will be the clinoid segment, like we just learned. And as we can see that we have an inferior hypophyseal artery and a meningohypophyseal artery, or meningohypophyseal trunk, that this is going to further divide into anterior hypophyseal, superior hypophyseal in different branches, are branches of tentorium, and it is going to supply tentorium here because all these structures are intimately related. So the branches of the intracavernous portion of the carotid artery that supply the sellar contents are the meningohypophyseal trunk. Likewise, we know the largest intracavernous branch, which gives rise to the inferior hypophyseal trunk, and McConnell's capsular artery, which arises directly from the internal carotid artery. The meningohypophyseal trunk arises at the level of the dorsum sella at or just below the apex of the first curve of the carotid. It returns forward after leaving the carotid canal. The inferior hypophyseal artery, on the other side, arises from the meningohypophyseal trunk and passes medially to the posterior pituitary capsule and lobe, and anastomose with its mates of the opposite side after supplying the dura of the sellar fluid. The McConnell's capsular arteries, they are frequently absent, and if they are present, they arise from the medial side of the carotid and pass to the capsule of the gland, the pituitary gland, and the dura lining the anterior wall and floor of the cell. So the blood supply of posterior pituitary comes from the inferior hypophyseal artery. The blood supply of the anterior pituitary comes from the main meningohypophyseal trunk, and the blood supply of the capsule comes from the McConnell capsular arteries, and all are branches of the internal carotid artery. Now the location of the nerves in the wall of the cavernous sinus are from superior to inferior. The 3rd nerve superiorly, and the trochlear, ophthalmic, and abducent nerve. This is what we always read in medical school as well. The abducent courses within the sinus on the medial side of the ophthalmic nerve and is adherent to carotid artery medially and ophthalmic nerve laterally, as we saw in the previous diagrams. So we learn about intercavernous venous connection as well. They are basically paired cavernous sinuses that are found in the margins around the gland, and the anterior intercavernous sinus pass anterior to hypophysis and posterior pass behind the gland. The largest of the posterior one is known as the basilar sinus. It's the most constant intercavernous connection across the midline. Another picture, not something to worry about. Like we know, we have seen this picture previously. We are just looking at venous connections a little bit better here. These are the paired cavernous sinuses here. This is our pituitary gland in the center, and these are the paired cavernous sinus. This is the right cavernous sinus, and this is the left cavernous sinus. The connection between the two cavernous sinus that is present anterior to the pituitary gland is anterior intercavernous sinus, and the one that is present posterior to it is posterior intercavernous sinus. The largest and the most constant of the posterior intercavernous sinus is known as the basilar sinus. So now that just the way the sphenoid bone is divided into different types depending on the pneumatization, we have different types of intercavernous connections. So let's just look at this picture and try to understand it. These are the lateral views, schematic views of the pituitary gland. This is a normal pituitary. This is anterior. This is posterior. If there is any intercavernous connection present anterior to pituitary gland, this is known as anterior intercavernous sinus. If it's going to be present posterior to it, this is known as posterior intercavernous sinus. And if it's going, the most constant, the largest one is basilar. So different patterns of pituitary gland, there are different patterns of cavernous sinus. Sometimes we have anterior, posterior as well as basilar connections. Sometimes we just have a basilar connection. We don't have an anterior or posterior connection. Sometimes we have anterior connection and basilar connection. Sometimes we have just posterior and basilar connection. Sometimes we just have anterior and posterior connection. So this is just for the academic purpose, not something very important to learn about. The last thing, the covering, the diaphragma sella, it's just like a curtain that is present on the forming the roof of the sella turcica. It covers the pituitary gland except for a small central opening in its center which transmit a pituitary stalk. The diaphragma is more rectangular than circular, tends to be convex or concave rather than flat, and is thinner around the infundibulum and somewhat thicker at the periphery. It's frequently a thin linear structure that would not be an adequate barrier to protecting the suprasellar structure during the transsphenoidal approach. So moving forward, like I thought, yeah, like we will look forward a little bit to the nasal cavity, because normally when we look at pituitary, normally when you're operating on pituitary, we go from below, we go from nasal cavity. So we will look at these images and then we will move on to a 3D image of sphenoid bone and sellar region just for a proper understanding. So as we can see, this is a very familiar picture. We are looking at the nasal anatomy from behind, from below. We are looking at the medial wall of this, and we can appreciate a sphenoid sinus here. So looking at it in a roton model, we can appreciate that this is the septum or the medial wall. It's formed by the ethmoid, perpendicular plate of the ethmoid bone, the vomer bone, and we have septal cartilage anteriorly. As we can appreciate, we have the sphenoid sinus present posterior to it here, and this is our pituitary gland, pituitary stalk. Gyrus rectus, the most inferior part of the frontal lobe, just present here, separated from the cribriform plate of ethmoid bone. This is the lateral wall, which is formed by the different concas, superior, middle, and inferior. Look at it in a roton picture, and we can appreciate the superior, the middle, and the inferior concha. We can appreciate the sphenoethmoidal recess that is present anteriorly and superiorly from the superior concha. We can appreciate the superior meatus present beneath the superior concha. We can appreciate a sphenoethmoidal recess is open into sphenoid sinus by the sphenoid ostia. This is the sphenoid bone, and this is a pituitary gland. We normally go from this approach to the pituitary gland. Opening, here we have removed the middle concha, so we can appreciate the ethmoidal bulla and the maxillary ostium, which open into maxillary sinus, and we can appreciate the sphenoid bone and pituitary gland. So this is how, when we normally insert a scope inside for pituitary gland, this is how our view looks like. If you're going to look center, we can appreciate the sellar dura, the two carotid prominences which are present laterally. We can appreciate a carotid bulge here and a carotid bulge here. If we strip off this dural opening, we can appreciate a pituitary gland here. And as we can see, it's intimately related to the two cavernous segments of the ICA. We can appreciate sphenoid sinus inferiorly and a pituitary stalk anteriorly, superior. If we are going to go a little bit lateral, we can appreciate the turns of the ICA and how it is intimately related to the cavernous sinus. Again, a similar picture, and again, we saw the inferior hypophyseal artery. It's been given off at this level from the internal carotid artery. So I'm going to pause it here, and I can see if we can see a 3D model of the sphenoid bone for better understanding.
Guys, still Dr. Areeba is putting 3D model up. If you guys have any question, you can use the chat box and we'll be happy to answer that question.
Okay, this is courtesy of Neurosurgical Atlas. So as we can appreciate here, this is how we were viewing it from the front. So let's make a little bit interactive. This is the corpus or the body of the sphenoid bone. This part, this is known as the lesser wing of sphenoid, and this is greater wing. We have this, yes, lateral pterygoid process, and this is medial pterygoid process. So as we can appreciate, zooming से issue हो रहा है. Zoom out नहीं. Okay. So this structure, this opening which is present between the lesser wing and greater wing of sphenoid is superiorbital fissure, and हम superiorly इसको देखें. So here we will have the two optic nerves which are joined together here with the optic chiasm. ठीक है. This is going to be the.
Okay,
yes,
continue.
This is going to be the trigeminal nerve. As we can appreciate, this is V1 distribution, V2 going into foraminotendon, and V3 going in foraminopage. Okay, this long cylinder nerve, this one, abduction nerve. It's like patli si, lumpy si, slender si nerve. And this one, which is arising dorsally and going frontal, is the trochlear nerve. This long cylinder nerve. Okay.
So Dr. Areeba is using Sketchfab right now. This is you can all go and see this online as well. So Dr. Areeba, till you struggle with the figure, what fiber constitute the Vidian now? That's one of the questions. And what is prefix and postfix chiasm?
So basically, prefix and postfix chiasm are type of chiasms that we normally have like connection with the internal carotid. So let me make a picture of it for better understanding. So what happens is that if you're going to view laterally, and this is the optic chiasm, and this is the pituitary stalk. So if chiasm is present anterior to or below, before the pituitary gland, this is prefix chiasm. And if it's present posterior to it, this is known as the postfix chiasm. So if we draw an imaginary line here from the pituitary stalk, and if we see that if chiasm is present anterior to it and posterior to it, this is known as prefix and postfix chiasm.
So this is important when you're doing a transcranial approaches in order to see the windows. If it's a prefix chiasm, then getting that window in between the two optic nerves would be a little difficult, and that is where you take other approaches like a lamina terminalis. Continue, Dr. If you have anything else.
No, sir.
So is there any other question? There's one more question, but I think you already mentioned that what from which part of ICA do the superior hypophyseal trunk and the inferior hypophyseal trunk and the capsular artery arises?
So,
Guys, if there are
the
any questions, use the chat box. Yes, Dr. Areeba, can you answer that?
Yes, sir. The meningohypophyseal trunk, it basically arises at the IC at the level of the dorsum sella. So, as we can see here, that at the level of dorsum sella, the superior hypophyseal trunk, meningohypophyseal trunk arises, and it's going to supply the anterior pituitary. And the posterior inferior hypophyseal artery arises from the same cavernous segment of the ICA, but it arises a little bit inferiorly.
And the capsular artery?
And the capsular arteries also arises at the same level. They are frequently absent, and if they are present, they arise from the medial side of the carotid artery, and they arises and pass to the capsule of the gland to supply it. They are frequently absent, and they arise from the cavernous segment of the ICA.
Okay, Dr. Pravat is trying to answer as well. If there's any questions, we're happy to take questions right now, guys. This is the time where you can clear your queries if you have one. Otherwise, this will be the end of the session. You can use the chat box to answer to ask any questions. So, Dr. Areeba, it was a nice presentation, very detailed presentation, and you had control over your presentation. If there's no more question, we would like to conclude the session. We'll see you all next week. We'll take care of yourself. Thank you, Dr. Areeba, for an excellent presentation.
Thank you, sir.
Thank you. We'd like to conclude the session now.